picture this. A doctor tells you they've found a small bulge in your aorta, that main artery in your belly, a little abdominal aortic aneurysm.
Mm-hmm.
And suddenly you're facing this big question. Do you go straight into surgery or do you, watch and wait?
It's a really tough spot.
Yeah.
And for years, that right path for these smaller aneurysms, it wasn't clear at all.
Yeah.
And that exact dilemma is what a really important piece of research set out to investigate. Today, we're taking a deep dive into a landmark paper.
Okay.
It's from the 2002 New England Journal of Medicine called Immediate Repair, compared with surveillance of small abdominal aortic aneurysm done by the Veterans Affairs Cooperative Study Group.
Right, the VA study, a real game changer, wasn't it?
Absolutely. It fundamentally shifted how we understand and manage this condition.
So whether you're in the medical field maybe, needing a refresher, or perhaps you've received this diagnosis yourself, or you're just curious about how these big medical decisions get made, this is for you. Because before this study, the actual evidence for managing these, smaller aneurysms, generally those between 4.0 and 5.4 centimeters, it was surprisingly thin.
It really was. There was a genuine lack of consensus. You had some surgeons worried that even small ones could rupture.
Which is terrifying.
Right. But then others questioned if the risks of immediate surgery were even justified for aneurysms that might, never cause a problem.
So this study aimed to bring some clarity.
Exactly. It provided some much-needed data to that whole debate.
Okay, so let's get into the details. How did they actually set this up? What was the study design?
So they used a randomized controlled trial, the gold standard for medical research.
Right.
They enrolled men aged 50 to 79 who had these small AAAs 4.0 to 5.4 centimeters and, importantly, were considered okay for surgery, not super high risk.
Got it. And then they were randomly assigned.
Yep. Randomly put into one of two groups.
What were the two approaches being tested?
Okay, so one group got immediate open surgical repair of their aneurysm, standard procedure at the time.
And the other group?
The other group went into what they called the surveillance program, basically watchful waiting.
Meaning regular checkups?
Yes, regular checkups with ultrasound or CT scans every 6 months. And in that surveillance group, they'd only operate if the aneurysm started causing symptoms or if it grew to 5.5 centimeters or bigger.
Okay, clear difference. Immediate action versus careful monitoring. And they followed them for a good while.
They did. The follow-up was quite long, ranging from 3.5 to 8 years, but the average was about 4.9 years.
And decent numbers of people?
Yeah, good-sized groups, 569 in the immediate repair group and 567 in the surveillance group. So pretty well balanced.
All right, so the moment of truth. What was the big takeaway? What did the data actually show?
Well, the primary finding was pretty striking. There was no statistically significant difference in overall mortality,
Right.
the chance of dying from any cause between the two groups.
No difference. Wow.
Yeah. When they compared immediate repair versus surveillance, the relative risk of death was 1.21.
Okay, so slightly higher point estimate for immediate repair.
Exactly. But the 95% confidence interval went from 0.95 up to 1.54. Since that range crosses 1.0, it means the difference wasn't statistically significant.
That's huge. It really challenges that instinct that earlier intervention is always better, doesn't it?
It absolutely does. It underlined how important it is to really understand the natural course of a condition and, critically, the risks of the intervention itself.
And did this finding hold true regardless of, say, how old the men were or how big the aneurysm was at the start?
It did. That lack of a survival benefit for operating right away, it was consistent across all the different subgroups they looked at. Age, initial aneurysm size, didn't matter.
So even though the risk of dying from the open surgery itself in that immediate group was fairly low, I think the paper said around 2.7%.
That's right, 2.7%. A low operative mortality for that era, definitely.
But even with that low risk, still no overall survival advantage.
Correct. And looking specifically at deaths directly related to the aneurysm itself.
Yeah.
Again, no significant difference. It was 3.0% in the immediate repair group versus 2.6% in the surveillance group. Very similar.
Okay, but what about the risk everyone worries about with surveillance, the aneurysm actually bursting, rupturing?
That's the key concern. Absolutely. The study gave us really valuable numbers on that. In the surveillance group, 11 patients did experience a rupture over the course of the study.
Okay, 11 out of over 500. What does that work out to per year?
It works out to about 0.6% per year, so less than 1% annual risk of rupture for these smaller aneurysms.
The 0.6%. Still, rupture is serious. Were those fatal?
Sadly, yes, 7 of those 11 ruptures did result in death. So it really highlights the trade-offs, doesn't it? The immediate risk of surgery versus the smaller but still present ongoing risk of rupture during surveillance.
It does. It sounds like the study gave doctors and patients much better information to actually weigh those specific odds.
Exactly. And it suggested that maybe the rupture risk for these specific smaller sizes wasn't quite as high as some feared.
That's a really important nuance.
It is. And another interesting point, they found that hospitalizations related specifically to the AAA were significantly lower, about 39% lower in the surveillance group.
Well, that makes sense, right? Fewer people having major surgery right off the bat.
Precisely. Fewer planned operations means fewer initial hospital stays for the aneurysm itself.
Now, you mentioned the study started way back in 1992. Endovascular repair, EVAR, that less invasive technique, wasn't really a big thing then, was it?
That's a crucial piece of context. When the ADAM trial kicked off, EVR was, very much in its infancy, mostly research protocols.
So this study was really comparing immediate open surgery to surveillance.
Exactly. Open surgery was the standard repair method then. By the time the results came out in 2002, EVR was becoming more common.
Did that timing cause any issues or discussions?
Well, yeah. There were actually some surgeons who worried that if EVAR proved to be safer up front than open surgery, which generally the early mortality was lower, that doctors might start using it to repair even smaller aneurysms, maybe without clear proof it actually helped long-term survival.
Ah, the treatment creep idea. Just because we can do something more easily doesn't always mean we should.
Precisely. So the ADAM trial's focus on open repair versus surveillance was really asking that fundamental question. Does fixing it early improve life expectancy compared to just watching it until it gets bigger or causes symptoms?
And those criteria for intervention in the surveillance group were quite specific, weren't they?
Very specific. They'd only operate if the patient developed symptoms related to the aneurysm, if the diameter hit 5.5 centimeters, or if it showed pretty rapid growth.
Like how rapid?
They define that as growing 1 centimeter in 1 year, or 0.7 centimeters in just 6 months. That signaled it was becoming more unstable.
Okay. Did they notice any differences in survival early on, like right after randomization?
Yes. Interestingly, there was a slight survival advantage initially seen in the surveillance group.
Really? Why was that?
It was mostly driven by that upfront surgical mortality, even though it was low at 2.7% in the immediate repair group. You avoid that initial risk if you wait.
But you said overall survival was the same, so that early difference faded.
Exactly. That initial benefit for surveillance didn't hold up over the long term. When they pooled the ADAM data with results from a similar big trial in the UK, the UK Small Aneurysm Trial, or UKSAT.
Ah, yes, the UKSAT trial.
Right. When they looked at the combined data, there was no significant difference in survival at 5 years, or even up to 10 years.
It's always good to remember the limitations of any study, though. What did the researchers point out for this one?
They were upfront about several things. First, the participants in the ADAM trial, being VA patients who met the criteria, were generally a bit healthier and had lower surgical risk than maybe the broader population of people diagnosed with AAA.
So the results might not apply perfectly to someone who's, say, much sicker.
Potentially, yes. Also, while the average rupture risk was low, the study did show that some aneurysms do grow quite quickly. A fair number reached the size threshold for repair within just a few years.
Right, averages don't tell the whole individual story.
Exactly. And the other big one was the lack of women. It was primarily a study in men, so generalizing directly to women needed caution.
And you mentioned the UKSAT trial found similar results. That must have really solidified things.
Absolutely. Having 2 large, well-conducted randomized trials done independently in different healthcare systems come to essentially the same conclusion. That adds enormous weight to the findings.
So looking back, what were the really big impacts of the ITM trial on clinical practice? How did it change things?
I'd say 2 major impacts stand out. First, it gave us a much clearer picture of the natural history of these small AAAs. It quantified that low annual rupture risk, less than 1%, which gave doctors confidence that surveillance was a reasonable, evidence-based option.
Provided a solid rationale for watchful waiting.
Precisely. But second, and just as important, it also showed that many of these small aneurysms do eventually enlarge. They don't just stay small forever in most cases. So surveillance doesn't mean no repair. It often means later repair.
Did the study give any numbers on how fast they typically grow?
It did. They calculated the average linear expansion rate, sort of the steady growth, at about 0.26 centimeters per year. That was over an average follow-up of around 3.7 years.
But you have to be careful with averages.
Absolutely. They noted that individuals could have more of a staccato growth pattern. Might sit stable for a while, then have a spurt of growth. So individual monitoring is still key.
It's fascinating what you said earlier about EVR. Even though it came along and had lower initial mortality risk than open surgery back then,
Yeah.
the overall number of procedures for small AAAs didn't suddenly skyrocket.
It is interesting, isn't it?
Right.
Unlike some other medical technologies, think about robotic prostatectomy after PSA screening became widespread.
Right, where procedure rates went way up.
Exactly. With small AAAs, even with a less invasive option becoming available, the evidence from ATOM and UKSAT seemed to hold sway, reinforcing that watchful waiting approach for aneurysms below that 5.5 centimeter threshold, unless they grew fast or became symptomatic. Practice didn't dramatically shift towards intervening earlier just because EVAR existed.
The evidence really mattered there. Did the study touch on screening or risk factors too?
It did, sort of as secondary points. The screening aspect was interesting. They found that screening men aged 50 to 79 with ultrasound picked up AAAs of 4 centimeters or larger in about 1.4% of them.
Which kind of supports the idea of screening that group.
Yes, it added evidence to the rationale for screening programs in older men. And risk factors. They confirmed the big ones. Definitely tobacco use.
Number 1.
High blood pressure. And general atherosclerosis hardening of the arteries. Family history was also noted as a factor.
Any factors that seemed protective?
Interestingly, yes. Being female and having diabetes mellitus were both associated with a lower risk of having a AAA.
Interesting. And just for context, they also looked at the rupture risk for larger aneurysms found during screening, right? People may be deemed unfit for immediate repair.
That's right. And those numbers really contrast with the small aneurysm risk. For aneurysms between 5.5 and 5.9 centimeters, the one-year rupture risk jumped to about 9.4%.
Wow, that's much higher.
And for those 6.0 to 6.9 centimeters, it was even higher, around 10.2% per year. So it clearly reinforces why that 5.5 centimeter threshold for intervention became so widely adopted. The risk profile changes significantly as they get bigger.
So summing it all up, it really sounds like the ATOM trial laid down some fundamental guidelines that have proven remarkably durable.
I think that's fair to say. Even in the EVAR era, the core principles established by ATOM regarding the threshold for intervention in asymptomatic patients remain highly relevant.
Okay, so for you, the listener, let's distill this. The key takeaway from our deep dive into the ATOM trial is this. If you have a small, asymptomatic abdominal aortic aneurysm, specifically between 4.0 and 5.4 centimeters, immediate open surgical repair, back when that was the main option, did not improve your overall survival compared to keeping a close eye on it with regular scans until it grew larger or caused symptoms.
And that finding was truly pivotal. It empowered a strategy of watchful waiting for many people, allowing for shared decision-making between doctors and patients based on solid evidence, avoiding upfront surgical risk when the aneurysm was small and stable.
Which brings us to a final thought for you to chew on. We've talked about how EVAR has evolved, how surgical techniques keep improving, how we're getting better at patient selection. So thinking about today, how do current strategies for managing these small AAAs still echo the ATOM trial's findings? And where might things be diverging, or what new questions are emerging now, decades after this landmark study?
That's the fascinating part, isn't it? It's a field that keeps moving. How do we best apply these principles with today's tools? What about specific subgroups? The questions continue, but the foundation laid by ATOM remains incredibly important.